Patients present to the outpatient department every day, complaining of severe burning during urination and a constant need to find a washroom. The urinary tract infection is common, but it is frequently mismanaged. On this digital pad, we are going to build a comprehensive, foolproof clinical framework to treat it. We will map out exactly how to identify the symptoms, verify the lab results, and write the precise dosages required for the final prescription. A systematic approach eliminates guesswork. You lock in an accurate diagnosis, and the patient gets immediate relief. This diagram shows a typical lower urinary tract infection, localized right here at the bladder. Patients will report a distinct triad of symptoms: a severe burning sensation during urination, a constant urge to go, and passing very little urine when they do. They will also describe a heavy pressure or a localized dull ache in the lower abdomen. The danger lies in assuming every infection stays in the bladder. You must check if bacteria have migrated up the ureters and engulfed the kidneys. Look directly for the 3 danger signs: back pain, high fever, and chills. If those 3 symptoms are present, this is no longer a standard OPD visit. The patient requires immediate emergency medical escalation. Before initiating antibiotic therapy, the physical symptoms of a localized bladder infection must be verified with objective data. We do this by ordering a urine routine and microscopy test, as shown on this digital lab report. First, check the pus cells count. If the value is greater than 10, the body is actively fighting off an invader. Next, check for nitrates. Bacteria in the urinary tract convert nitrates into nitrites, so a positive result here confirms that the invader is bacterial. Hitting these 2 specific benchmarks provides the exact clinical evidence required to begin targeted antibacterial treatment. Returning to our digital pad, we can now fill out the first quadrant, the antibiotic protocol. The most effective targeted option to eliminate UTI bacteria is nitrofurantoin at a dose of 100 milligrams. Prescribe 1 tablet to be taken twice a day, or BD, for a duration of 5 to 7 days. The antibiotic will eventually clear the infection, but the patient needs immediate relief from the severe pain of bladder spasms today. To stop those spasms, we add a pain management note, flavoxate 200 milligrams, also taken twice a day. This acts as an antispasmodic to relax the bladder muscles. This dual medication approach neutralizes the biological root cause while immediately stopping the patient's suffering. Step 3 is altering the chemical environment of the urinary tract to soothe the internal tissue. We achieve this by prescribing a urinary alkalizer, specifically disodium hydrogen citrate syrup, commonly known as Alkasol. Instruct the patient to mix 2 spoons of the syrup into half a glass of water, to be taken 3 times a day. This mixture actively lowers the acidity levels in the urine, directly neutralizing the burning sensation. Finally, none of these medications work optimally without high fluid volume. Set a strict target for the patient to drink 3 to 4 liters of water every single day. That heavy hydration acts as a mechanical flush, constantly pushing the bacteria and the medication through the urinary system. Looking at our completed flowchart, we now have a cohesive 4-part defense plan. We mapped the localized symptoms, confirmed the bacterial presence with specific lab metrics, deployed a dual tablet approach, and implemented a strict hydration and alkalizing routine. By systematically executing these steps, you isolate the infection, protect the kidneys, and ensure a rapid recovery for your patient.